Now moving on to fractures of the calcaneum, that is the heel bone, which is very important especially when we are weight bearing. As you know, the fractures of the calcaneum could be intra-articular or extra-articular, and it's a kind of a cylindrical bone with an oblong shape which is actually articulating with multiple other bones. If you see it over here, it articulates and forms a subtalar joint with the talus above it. It also forms a joint with the cuboid called as calcaneal cuboid joint on the lateral side. And similarly, on the middle side, you have a ledge-shaped area called as sustamentum tali, which is actually articulating with the other tarsal bones. And as a result, it's actually providing kind of if you see a tripod mechanism, that it's actually acting as a central pivot to all the medial and lateral arches of the foot. As you can appreciate, it forms the tibiofibula forms an ankle joint with the talus, and talus is forming a subtalar joint with the calcaneum. This could be, now the important point is, because a talus has an articulation with the calcaneum, similarly cuboid has an articulation with the calcaneum. So if the calcaneum gets disrupted, it's an intra-articular fracture, which means there would be definitely problem with the lateral as well as the medial arches as well. Now coming to the mechanism of injury, how the calcaneum can get fractured. The most common mechanism is always by the fall, especially when a person falls from a height and lands on its feet. That is actually all the energy is being transferred from the falling towards the lower part of the body in form of a calcaneum, and goes actually towards this. Usually this results in a crush type of an injury. What's important is, as this is the most common mechanisms, and what's important over here, it is to always understand that whenever you have a calcaneum fracture, especially bilateral calcaneum fracture, always rule out other associated injuries. When a person is going to fall from a height and land on its feet, although the calcaneum will be fractured, but there may be associated pelvic injuries, there may be associated crush or injuries of the spine as well. So whenever you are seeing a patient with bilateral calcaneum, must evaluate pelvis and spine injuries, which may be associated and usually are commonly associated with calcaneum fractures. Then it may be associated with isolated fractures as well as injuries of the tendon Achilles. As you know, the tendon Achilles is actually attached on the posterior aspect of the calcaneum, and actually tendon Achilles has a role in when we have gait mechanisms. There may be a rupture, maybe a sprain, or maybe a complete avulsion from the calcaneal bone. Then it may be associated with the usually ankle injuries. Whenever we have a bimalleolar or trimalleolar fracture, maybe trauma force may be great enough to have ruptured the ankle injuries as well as associated extra-articular calcaneum fractures. And then could be direct blow, especially for example in a car accident, when person tries to brake the pedal, and the resulting could be this injury results when a car actually goes above the ledge, and actually the injury force is coming from downwards and going upwards, and this may lead to a classical extra-articular type of a calcaneum fracture due to the direct blow. Now coming to the pathological anatomy. This may be an intra-articular fracture. As I told you, if you appreciate over here, the fracture intra-articular extending into subtalar joint over here, although the calcaneal cuboid joint appears only subluxed, and then there is all the way going back into it as well. Or it could be extra-articular. Now this kind of a fracture in which all the joints are actually stable, only the calcaneum is fractured. This is called an extra-articular fracture as well. Now, extra-articular fractures can be further classified subclassified as well, because then there are different parts of the calcaneum. There is a tuberosity on which the tendon Achilles is attached, and actually as tendon Achilles is contracts, there actually avulses the tuberosity. So there may be extra-articular avulsion fracture of the tuberosity. There's an anterior process which articulates with the cuboid. So there may be associated extra-articular anterior process fracture which is not involving the calcaneal cuboid joint. Or it may be associated fractures of the body which actually form the main bulk of the calcaneum. If you see it from the back, if you can appreciate it over here, there is a fracture line going like this, as well as going into the sustamentum tali, which is actually a ledge-shaped structure of the calcaneum on the medial side. And if this is, although it appears to be intra-articular, but usually as the system tendon does not articulate with the talus, so its fracture actually is rarely intra-articular. Now coming to the intra-articular fractures. The problem is actually with the intra-articular fractures. Why? Because first of all, it's forming a subtalar joint with the talus and forming a calcaneocuboid joint with the cuboid. And if its fractures will result in usually problematic biomechanics of the foot, and patient may not be able to ambulate properly, or eventually it will produce a lot of arthritis, and during every ambulation and gait cycle patient have a lot of pain and may require some form of orthodesis later on. So one way of fracture, actually this is called as primary fracture line, which is usually most commonly goes from posterior medial, which is on this side. This is the system talocalcaneal medial side. This is the lateral side towards the anterior lateral area. Then could be a secondary fracture line. If you see appreciated over here, this is the primary fracture line, and this is the secondary fracture line, creating this looks like a tongue. So it's called as tongue type of fracture, a tongue variant sometimes formed. Or it could be depression of the joint, that this is the primary fracture line going from posterior medial towards anterior lateral, and it has resulted in depression of the subtalar joint. Although talus is not fractured, but subtalar joint is actually depressed. Now there is another way of classifying it actually as well. Sometimes the x-rays are quite deceiving. It may not be properly visible because x-ray on a calcaneum, usually when you take an AP view, mainly the bone visible is always the talus and the ankle joint and subtalar joint. And you take a lateral view only, you can take it either from medial lateral side, but there are different, on medial side you have sustenance tali, and on the lateral side you have different structures. So you cannot have a proper view of it. And the other views are actually, there are Canale view, then there are Harris views as well, but even they have limitations. So the ideal option is usually CT. And then we classify more recently called as the Sanders classification on the basis of the CT. Other way of it is intra-articular fracture is type 1, which actually involves the subtalar joint that is below the level of talus. And then there are type 2, which may involve more than subtalar as well as calcaneocuboid joint. And then maybe type 3 as well, in which there is highly comminuted subtalar along with the comminuted calcaneocuboid joint. Then, as I told you, there is Sanders classification for intra-articular classification. And why? Because there is always limitation of x-rays. Sometimes it's not clearly visible exactly what is the fracture pattern and fracture geometry. Type 1, actually this is how they view it. This is a coronal view, and on coronal view they see it how many lines there is. Type 1 is actually either no fracture, or type 4 is multiple comminuted fracture. Type 2 is actually a two-part fracture. When you will have two-part fracture, you will have actually type 2 is there are on type 1 you have one fracture line, and on type 4 you have four fracture lines. So when you have one fracture line, it becomes a two-part fracture. When you have two fracture line, it becomes a three-part fracture. That is, if you can appreciate over, this is the one fracture line, this is another fracture line, so it becomes a three-part fracture. On type, then it has variants as well in form of 2A and 2B, depending upon exactly how the fracture pattern is there, or even the 2C when it involves the sustenance tali. Then type 3 is you have three fracture lines, so it's going to divide the calcaneum into four parts. If you see it over here, there are three fracture lines which are crossing, making it a 1, 2, 3 and 4-part fracture. It could be further subdivided into 3A and 3B depending upon how it is actually divided. Coming to the clinical features, as I told you, that is what is more important. Clinically, patient will complain of, first and foremost, is always the heel pain, and ankle movements may be possible, but they will be painful. Above all, there may be a swelling and blister formation, and pain may be most commonly on the heel area, and there will be a lot of tenderness as well. Could be thick and tender surrounding tissues, especially if it has been an old injury and a patient may have lingered it on, and there may be an acute or chronic onset kind of thing, then there may be associated with ligamentous thickening and problems for the patients later on. And the last would be the compartment syndrome. That is the most dreaded one. Usually because there is the foot is actually a closed compartment, and if there is a lot of hematoma collection over there, this may raise the compartment very high, and this may actually impede the blood flow to the phalanx and metatarsals, and this may lead to some form of a compartment syndrome. Now coming to the imaging, if you see, this is a lateral view. Although you can appreciate this is an anterior process, this is the subtalar joint and this calcaneal joint, and this is the posterior process on which the tendon actually sits, but you cannot appreciate clearly where it's a sternum tali. So if there is an isolated fracture of that, then it will be difficult to get it on X-ray. But if you get it, you have at least have an idea of what kind of a fracture it is. But if you see this looks like an extra-articular fracture involving this part of it when the tendon actually is actually attached. It does not seems to be involving the subtalar joint. But if you get a CT of this, then you can appreciate actually it's a comminuted fracture. That is why X-ray is unfortunately not enough, and you have to get a CT of the calcaneum to get exactly a 3D view of how much and what is the variation of the geometry of the fracture. And it is actually a comminuted intra-articular type of a fracture, which probably, if you count the pieces, it's probably Sanders type 4 injury. Now this is on X-ray, although it looks like a very nasty injury. There's multiple fractures and there is a lot of pieces of the bone. Probably this is where, but you cannot appreciate whether there is involvement of subtalar and calcaneal joint or not. So if you go for a CT in this, you can clearly see that subtalar joint is not only subluxed and involved, but there is also involvement of other joints as well. Now coming to the treatment, there is an initial treatment which may involve like elevation of the leg and foot so that there is less to decrease the chances of formation of compartment syndrome. We have to go for ice or cryocuff as well. That's actually not only reduces the swelling and inflammation, but also decreases the pain. And eventually, after getting X-rays and CTs and properly actually for diagnosing it, what's classifying the injury, then you may have to go for open induction internal fixation in form of calcaneal plates are also available. Then there are K-wires as well as the screws. All types of hardware is actually available depending upon, it depends what type of injury it is. If it's highly comminuted type of fracture, then you may have to go for calcaneal plates with multiple screws. But if it's an isolated type of injury in which there's only avulsion type, you may have to go for a single screw as well. If it's an extra-articular fractures, now this is where the important point is. Usually this mostly treatment is directed intra-articular fractures. And why? Because we have to calculate the angle of the bowler and Gaussian angles, and if they are really depressed, then we have to understand that we must restore the calcaneal height. But usually in extra-articular fracture, the bowler and Gaussian angles are actually within the normal limits. So the subtalar joint is intact, there is actually the height of the calcaneum is intact, so we can go for more likely a conservative approach. That includes the ice pack and elevation to reduce inflammation and pain, compression bandage so that the swelling decreases, ankle exercises, and we may have to go for sprint for a few weeks and keep patient non-weight bearing for 6 to 8 weeks, and then eventually start a gradual first partial weight bearing, then complete weight bearing, and gradually range of motion and strengthening exercises later on. Coming to the extra-articular fracture, if you see this is a CT. It is look most like a fracture of the anterior process. There may be an avulsion fracture type. It looks like that. And fracture of the tuberosity. Now, when this kind of an injury occurs, you need to make it sure that assess the integrity of tendon Achilles ligament. Is it just due to the excessive avulsion of it, or there may be associated with sprain and rupture of the tendon Achilles as well? But if you see this is actually a fractures of the body. But these X-rays sometimes are highly deceiving because there may be a fracture line going right into the intra-articular, or there could be a simple fracture of this. But whenever you get this kind of a scenario, you must calculate first the angle of Gaussian and Bowler, as well as get a CT to make it sure that it's not an intra-articular fracture. And if it's an intra-articular fracture, you need to understand whether it's displaced or undisplaced as well. If intra-articular fracture is an undisplaced fracture, then you can treat it like an extra-articular fracture, because what's important over here is to restore the joint anatomy of the subtalar joint and restore the calcaneal height. If it's undisplaced, even if it's intra-articular, this will produce little minimal arthritis, calcaneal height is good, subtalar joint is okay, then you probably can go for conservative measurement in the form of compression bandaging, ice packs, elevation of leg and foot, that is all to reduce pain and swelling and inflammation. And then you can go for ankle exercises, but first you have to go for non-weight bearing for at least 6 to 8 weeks, and mostly we keep it in a splint. So once the fracture heals, then we can start keep the patient in non-weight bearing. After 8 weeks, then we convert it to partial weight bearing, then eventually full weight bearing in strengthening exercises of the ankle joint. If it's a displaced intra-articular fracture, as I told you, what's important is to restore the anatomy of subtalar joint and restore the height of the calcaneum. That should be the goal of the treatment of the calcaneum fracture. And then usually I have to go for open reduction internal fixation with a locking kind of a plate. These are called as calcaneum plates, or even the screws or K-wire sometimes are enough as well for displaced intra-articular fractures. Now coming to the complications. Yes, everything has its own complication. For example, patient suffered from some form of trauma or a fall and resulted in injury to the calcaneum. Then it could be in the early complications may include swelling and blistering, and the most dreaded one is always the compartment syndrome. Whenever you have a foot injuries, we must be on the lookout for the compartment syndrome, because foot is usually a closed compartment. Then later on, once we fix it or we apply the POP cast or some form of splint, and once we have treated the fracture, then could be the late complications. This could include the malunion. This may be a problem leading to subtalar arthritis, or peroneal tendon impingement, which may be irritating the patient, and patient may complain of pain later on. There could be insufficiency of tendo achelis due to if the fracture line has actually involved the calcaneal tuberosity, or talocalcaneal stiffness and osteoarthritis. Osteoarthritis is usually the most common and eventually requires some form of treatment, form of orthodesis or ankle replacements. Why? Because eventually once intra-articular fractures produce some form of arthritis always, and this may be very damaging, and patient may complain of a lot of pain later on. Now coming on to the mid-tarsal injuries. As I told you, the tarsometatarsal articulation is also important, as well as the tarsal bones actually form the midfoot of mainly. There are multiple bones like naviculum. There is made 3 cuneiforms: the medial, the middle, and the lateral cuneiform, as well as the cuboid. There are different types of injuries which can occur. For example, there could be medial stress injuries which may be occurring on the talocalcaneal area or in the naviculum mainly. There could be longitudinal stress injuries, which could be form of maybe ligamentous injuries in form of which are going anterior to posterior, like for example injuries involving between the middle cuneiforms. There could be lateral stress injuries involving the cuboid, or it could be plantar stress injuries as well, as there is a transverse arch which is actually formed between the medial and the lateral plantar arch. So this transverse arch could also be disrupted as well. This will result in a crush injuries. Crush injuries, when a heavy sub object actually falls on the midfoot, this may lead to fractures and crushing of all the bones and ligaments. Now, mid-tarsal injuries, what are the clinical features? Usually the pain and swelling is in the midfoot area. If you see, this is the ankle, and then this area in front before the metatarsal actually bases start, this area is called as the midfoot, and usually pain, increased swelling in the mid-tarsal area is actually suggestive of tarsal injuries. Painful movements and tenderness is always there, because during the propulsion system, when during the push-off phase, that has to act actually, the force has to transfer from the calcaneum to the forefoot, and it goes through the midfoot, and whenever the force goes through the midfoot, it results in a lot of pain during every movement. And then there is maybe associated with some form of valgus deformity as well. Now, the midfoot could be in form of a cavus or valgus deformity. Usually, there may be correlation in children. There may be associated with tarsal collision, or this midfoot injuries could result in hindfoot valgus or varus as well. So we need to be sure that the problem is actually in the midfoot or in the hindfoot. Now coming to the imaging, if you see on an AP view, you can appreciate this is the talus head, which is actually articulating with the naviculum, but this appears to be a talonaviculum dislocation. Then if you see this over here, this is a longitudinal compression fracture of the same joint, but all you cannot appreciate it because this appears to be a cuboid, which is actually pushed forward and naviculum is going in this direction. And this is CT of a reconstructed CT after reduction. If you appreciate it over there, this is the medial cuneiform, middle and lateral cuneiform, and this, although naviculum is intact, but you can appreciate the lateral cuneiform as well as the cuboid as having a crushed fracture. Now coming to the mid-tarsal injuries. There may be, the treatment includes the ligamentous. If there is only ligamentous strains, what is important is to have actually a bandage or a crepe bandaging or some form of bandages can be used to reduce the stress and swelling and pain of the patient due to ligamentous injuries. If there are undisplaced fracture, they can be applied a below knee cast in form of PFP boot, or we can only apply a splint and keep the foot elevated for a few weeks so that the patient, once the swelling and the pain settles down and the urine starts over that. If it's a displaced fracture, this usually requires ORI. Why? Because there is actually a forefoot and hindfoot articulation is actually disrupted. If the tarsal bones are dislocated, then the propulsion system of the foot during the movement is actually completely lost. So you need to restore the anatomy so that the biomechanics of the foot can be restored. So if there is a displaced fracture, you need to go for open reduction internal fixation, which could be in form of cavoids, could be in form of screws, or could be in form of plates as well. Now, fracture dislocation treatment. If you see it over here, this is probably talonavicular joint has been restored in form of, and 2 cavoids been applied and splinted actually in a cast as well. Then once fracture reduction has reduced after 3 to 4 weeks, you remove the cavoids, then you can start the foot exercises which mainly concentrate on the midfoot area, not on the forefoot or the hindfoot. And if there is an undisplaced fracture, we may have to actually keep it immobilized for a longer period of time in form of a below knee cast mostly, or it could be in form of open reduction and screw fixation. Screw fixation sometimes is required, especially when you have a large piece of bone and it's not a comminuted fracture. Coming to the comminuted fractures, if you have this sort of a situation, you can appreciate having a navicular comminuted fracture. You probably require a foot splintage in form of a splint or a cast. Then you may require an early orthodesis, because despite the excessive treatment, there will be some form of arthritis as well, and you need to provide a stable fixation in form of either a screw or a plate, so that because cavoid construct will not be stable enough. Or we may have to go for interposition in some form of a bone graft as well, because the bone which will be lost in form of avascular, that has to be replaced in form of a bone graft, which could be an autograft in form of cancellous or cortical autograft. Now coming to the tarsometatarsal injuries. Why it is very important? Because actually tarsometatarsal joint is the sort of a fulcrum at which the biomechanics are actually based. It's basically present between the joint. There is called as a Lisfranc joint. And why it was named as Lisfranc? Because actually the Lisfranc was a French surgeon who has started this amputation of the forefoot amputation in the First World War, and actually that is why this joint was named after that surgeon. And Lisfranc joint is actually formed at the Lisfranc ligament, which is actually present and connects the second metatarsal with the medial cuneiform. If you see this on the lateral view, there's a second metatarsal which is actually connected by a Lisfranc ligament to the medial cuneiform, which is articulating with the first metatarsal. So that is actually from the Lisfranc ligament. The most common mechanism of injury of disruption of the Lisfranc ligament is actually what is actually shown over here: hyperflexion and hyperpronation. If too much force is being applied when the foot is actually in a plantar flexed position, if the foot is in this position and a lot of force is applied, downward force is actually applied. For example, a patient falls with the foot in this position, or for example, in case of ballet dancers, when their foot is in this position, a lot of force is actually applied suddenly, this results in a Lisfranc ligament injury or Lisfranc ligament rupture. Now, this could be isolated ligamentous rupture, or it could be associated with the fractures as well. And when we going for the classification generally involves that there is the isolated ligamentous injury, or there may be associated fractures as well. One is called as homolateral Lisfranc, in which all the ligaments are ruptured and whole of the foot is actually gone in one direction. And you can clearly see that there is a problem between the tarsometatarsal articulation. Other is the divergent type, or then there is an isolated type as well. Isolated is when this Lisfranc ligament is injured, the first metatarsal is actually gone out of the sync and other four metatarsal is actually intact. Now, why it is important? If you see all of the foot would have gone this way, then how would the tarsometatarsal articulation take place during the movement? And even if it's an isolated one, you can appreciate that the medial arch is actually not now part of the biomechanics of the foot, and foot cannot actually work on transverse and lateral arches. It has to work in a sync with the medial, lateral and transverse arch. And then there is a divergent type, in which the injuries are toward the lateral as well as the medial arches, and actually the divergence occurs that medial arch is going more medially and the first metatarsal is more medially displaced and the other four metatarsal are more laterally displaced. This is called as the divergent type of a Lisfranc ligament injury. Now, if you see an imaging, if it's an isolated ligamentous injury, one has to be on very careful in viewing this kind of X-ray, because bone may not be injured and you have to look for a flex sign which is actually present between the first and second metatarsal. For example, if you see this is an X-ray, what you need to look at on a true AP view, second metatarsal should be aligned with the middle cuneiform. If, as you can appreciate over here, this is how it's coming, and you can see that probably middle cuneiform is slightly displaced. This means there's something wrong, and there may be a flex sign over here. It may not be present as well, but you need to be on the lookout for the Lisfranc ligamentous injury. Now, coming to the treatment. Now, Lisfranc ligament injury is actually a form of a fracture dislocation, which may be associated with fracture or which not be associated with fracture. Initial treatment is a cast or boost for undisplaced spine. If there is on the AP as well on the lateral view, there is actually no dislocation or subluxation of the second metatarsal. But if you see on an AP view there is a subluxation, or on a lateral view second metatarsal is quite anterior to the first metatarsal, then you have to go for reduction stabilization, which could be in form of K-wires or screws as well. So what you need to restore is that is what's more important, is that second metatarsal must be aligned with the middle cuneiform on AP view, and first metatarsal should be aligned with the medial cuneiform. That should be the goal of the treatment in reduction of the Lisfranc ligaments. What's important is the most common and rare complication of the Lisfranc ligament is always the compartment syndrome, as it's mainly in the midfoot, and sometimes there may be associated fracture and hematoma will be collecting the middle of the foot, leading to a lot of pressures, intracompartmental rise of pressures leading to compartment syndrome. Now, coming to the injuries of the metatarsal bones. As you know, there are multiple metatarsals, which may there are 5 in number, which may be fractured over here in the level of the base. They may have their head cord fracture, or there may be fracture of the shaft as well. Now, fractures could be comminuted, could be a spiral, could be a simple transverse fracture as well. As I told you, there could be stress fractures involving the metatarsal, especially in the athletes and army recruits, especially what is called as march fractures. There may be fractures of shaft, which may be spiral, oblique, or even a transverse one as well. There may be fractures of neck of the metatarsals or head of the metatarsals, or they may be involving the base of the metatarsal as well. Or it could be a proximal fracture involving the base. Injuries to the metatarsal bone can be managed. There may be different form of fractures, maybe spiral one, like this. If you see it over here, this is involving the spiral fracture of the mid shaft of the fifth metatarsal. Could be avulsion fractures. For example, if you see it over here, this is an avulsion fracture of the base of the fifth metatarsal. There could be crush fracture, in which multiple metatarsals may be injured and they may be having a problem with. There could be either mid shaft injuries, or it could be that one metatarsal injured in the mid shaft. There could be another metatarsal injured at the base, and there could be another metatarsal may be injured near the neck or the head area. And then there are insufficiency fractures, for example, which may occur due to stress, or the patients who are in having a problem with their immune systems, for example, or having bony diseases such as osteoarthritis or rheumatoid arthritis as well. Now, coming to the clinical features. When a metatarsal fractures, what are the signs and symptoms? Usually the forefoot or the midfoot is mainly this area where it swells. If it's involving the metatarsal head, there will be more pain toward the forefoot area. If it's involved the base, it will be probably the midfoot area which would be more involved. There will be definitely swelling, and above all there will be bruising. If you can appreciate it over here, either this involves the metatarsal fracture, the fourth or the fifth one. Now coming to the imaging, you have to get an AP and lateral view of the foot. On AP view, if you see this, probably if you can appreciate it over here, looks like a cortical breach over here as well. That is the third, fourth metatarsals. They both are involving the fractures of the neck of the metatarsal, but they, if you see, can appreciate, they are very minimally displaced. Probably this kind of fracture does not require the fixation. And on CT, you can appreciate there's a callus formation which is going on, and probably there is involving the second metatarsal mid-shaft fracture. Now coming to the treatment of undisplaced or minimally displaced fracture, the treatment is usually conservative in form of a below knee cast or a boot splint, or it could be then once it has healed over 4 to 6 weeks, we can go for active movements and exercises. And usually you have keeping them partial weight bearing actually impedes the kind of a healing. Once a 4 to 6 weeks cast has been applied, then we can ask the patient to go for full weight bearing, which is more important because that will actually induce a quick healing response. Now coming to the displaced fracture. If there's a lot of displaced fracture, then which may require some form of fixation as well. Initially, it can be treated in form of immobilization or below knee cast, or we can go for simply K-wiring and then apply the cast over the top of it. Or we can also apply screw as well. If, for example, this is a classical Jones middle zone fracture of the fifth metatarsal, you can go for a screw fixation so that it does not go into some form of non-union. Now coming on to the fractures of the fifth metatarsal base. Why it is important? Because it has a special actually of value, because the problem is that it may go into some form of a non-union. So we're going to be discussing this fractures of fifth metatarsal base as a separate entity. It's actually classified that there's a cuboid which is actually articulating with the fourth or fifth metatarsal. Base of the fractures can be in form of 3 zones. Zone 1 is actually the tuberosity or avulsion fracture, which is usually occurs in this zone, which is called as avulsion fractures mainly. Then zone 2 fractures, which occurs actually the junction of the diaphysis and the metaphysis and the diaphysis, and then there could be fracture of the diaphyseal stress fracture in zone 3. This zone 2 fracture, which occurs at the junction of the metaphysis and diaphysis, is actually important because this is the most common area of going into a non-union. So if it's zone 1 or zone 3, that can be managed conservatively, but zone 2 must be managed operatively so it does not goes into some form of a non-union. So coming to the types of the fracture, as I told you, that is why this avulsion fracture is called as dancer's fracture, especially it is more common in the ballet dancers, because this occurs when the foot is in plantar flexion and the muscle suddenly contracts, leading to this kind of avulsion injuries. Then this zone 2 injury, which occurs at the metaphyseal diaphyseal junction, is usually called as Jones fracture, and it has a high propensity to go into a non-union. Then there is called as shaft fracture, or zone 3 injuries are diphyseal shaft fractures, which may occur in the fifth metatarsal as well. Now coming to the treatment, as I told you, the most importantly, it's initially treatment. If it is a type 2 injury or zone 2 injury, which is called as Jones fracture, then you need to fix it go for open adduction internal fixation with form of a screw, because it's going to go into a non-union. But zone 1 and zone 3 injuries can be managed conservatively in form of a immobilization of foot in form of a below knee cast or a foot splint. And then we have to go give them bed rest and support as well, and allow the time for the fracture to heal for 4 to 6 weeks. Now coming to the stress injury or march fracture. This is also called as stress fractures, which most commonly occurs in the diaphysis of the fifth metatarsal. Usually it's rarely occurs in the phalanges, but more commonly it's in the metatarsals as well as in the tibia. And why it's common? Because it's commonly occurring in the usually army recruits, that's why it's called as march fracture, but it can also occur in athletes as well, or especially those athletes who are undergoing a marathon, who run a marathon. Usually this results in stress fractures. Coming to the imaging, image may be completely normal. Sometimes we may have to go for some form of an MRI to assess the stress fracture, or it could be this kind of an image. If you see this is second metatarsal, it looks like something happened here, and probably it has healed as well. So actually what stress fracture is multiple micro fractures which have occurred with no macro fracture visible on the x-ray. So you can appreciate there's something wrong. This cortex is going like this, and then this is this, but you cannot appreciate a clear-cut fracture over there as well. So usually the appearance of stress fracture is quite subtle, and one has to be on the lookout, especially when after taking a history examination, we have to carefully evaluate the x-rays for some form of stress fracture, especially if the other person is an army recruit or some form of an athlete who is taking part in marathon. Then coming to injuries of the metatarsal phalangeal joints, like called as turf toes. And why it is important, if you see this is resulting in metatarsophalangeal dislocation. This could be subluxation, dislocation, or even the fractures of metatarsophalangeal joints. If you see this is a second metatarsophalangeal dislocation and subluxation. How would you see this? Because it has actually dislocated more plantarly, and you can appreciate that it's actually, if you see lateral view, the phalanx would be below the level of the metatarsal head. Then comes the fractured toes. Although they are rare, but they can get fractured, especially due to a very heavy object falling on the person's foot, and most commonly it falls in the forefoot. Then, as you know, the great toe or the hallux has actually 2 phalanges, the proximal and distal one, while all the 4 metatarsals have actually 3 phalanges, proximal, middle, and distal one. It may be, and treatment mostly is always conservative, except if it is highly comminuted or it's actually open. It may require some form of operative treatment. Usually it's sterile dressing, antibiotics may be given if it's associated with injury, and supportive boots and splints are more than enough to treat the fractures involving the phalanx of the foot. Coming to the fractures of the sesamoid, again, as like stress fractures, these are also very subtle and rare fractures, and one has to be on lookout for these, especially if there is an associated chronic history of a pain, which is mainly of the hallux. There are 2 bones which are called the sesamoid, which are present just beneath the head of the first metatarsal, and actually they are present in the tendon of the flexor hallucis longus. There is the medial and the lateral head. This is the lateral head, and this is the medial head. Now these 2 bones are intertendinous, that is why they're called as sesamoid, and they are actually present inside this. Usually the pain around the area of the head and more towards the plantar side, and tenderness over the plantar area actually you may think of having a sigmoid fracture. But once we get an x-ray, you need to be on the lookout for the subtle changes of the sigmoid. If you see it over here, this is right side, this is the left side. Right side appears very much normal. Left, if you see, the medial sigmoid looks normal, but if you view it very clearly, there is a very thin line on the lateral sigmoid which is visible once you view it with a high index of suspicion. Usually, if you normally, one would easily miss these type of fractures, so we need to be very careful when we are taking history and examination, and we need to be on the lookout for these type of sigmoid fractures. Coming to the treatment, usually as they are intertendinous, they are not displaced unless the tendon is damaged as well. So mostly the treatment is, they are undisplaced fractures, we apply ligament injection so that they become pain-free, apply the splint so that patient keeps non-weight bearing for a few weeks. Once the fracture heals, then patient can start the active and full weight bearing straight away with not a lot of complications, and we may have to give analgesics as well. Thank you very much. Keep watching sqadia.com.